Okay, so remember we talked about pulmonary hypertension with newborns, and remember that in the fetal phase, pulmonary hypertension is normal. We want high pressure on the right side. The vessels are constricted, the lungs are collapsed because most of the blood needs to bypass and go into general circulation, be circulated through the placenta for oxygenation. So remember also that at birth, that system has to change. The baby takes a breath, opens the airways, which decreases pressure. That increased oxygen level relaxes the blood vessels, which also decreases pressure. And so that pressure equalizes, hopefully, as we cut the cord, right? So what happens if those vessels don't relax because this preemie cannot get in adequate oxygen? That means the pressure in the pulmonary vessel stays higher, and that causes a right to left shunt. So I want you to think about where blood is going on the right side of the heart, right atrium, right ventricle to the lungs to get oxygen, left atrium, left ventricle to the body, right? So what if a good part of that blood is moving instead of going right atrium, right ventricle to the lungs? That blood is going through the foramen ovale to the left atrium. And also when we get to the pulmonary arteries, going through that ductus to the aorta. So the blood is not going through the lungs. It's bypassing and going out to the body. We don't have a placenta to oxygenate anymore. And so that baby is not getting oxygenated. So pulmonary hypertension with a right to left shunt is really dangerous because the baby cannot get oxygen. So prematurity is one cause of this. There are some other newborn complications that can cause it. Meconium aspiration, if the baby aspirates meconium into the lungs and develops a chemical pneumonia from that. Congenital diaphragmatic hernia, that's when there's an opening in the diaphragm that allows abdominal contents to move up into the chest. Congenital heart defects, which we have a whole lecture on later, and respiratory distress syndrome. So all of those things increase the risk of pulmonary hypertension. What does it look like? Okay, this baby cannot get oxygen. It can breathe in and out, or it may breathe in and out, but even if it does, the blood's not circulating through the lungs. Okay, so hypoxia, cyanosis, respiratory distress, tachypnea, grunting, retractions, decreased peripheral pulses and prolonged capillary refill because of poor peripheral perfusion, shock. This baby looks bad, okay? Management, supplemental oxygen, because hopefully that will relax the vessels to allow blood to circulate through the lungs. Assisted ventilation is needed. Sometimes vasodilators are given. They actually, one of the meds that or there are meds may be given to vasodilate to open up those pathways to the lungs. We want to maintain acid-base balance. And so if that baby's getting acidotic, remember acidosis constricts the pulmonary vessel. So they try to fix the acidosis, prevent episodes of hypoxemia and hypercapnia. Okay. Inhaled nitrous oxide is one thing that is sometimes used because it relaxes the pulmonary vessels. So inhaled nitrous oxide. And if all else fails, they use ECMO if the baby meets ECMO guidelines. Because remember, our small preemies can't use ECMO. But if they can use ECMO, they oxygenate that way until, and putting that oxygenated blood back in may relax the vessels. Pneumothorax is a collapsed lung, and pneumothorax is more common with premature infants because their lungs are softer and more fragile. It can happen during or after delivery. Remember that the chest is squeezed during delivery, and then when it expands, the negative pressure hopefully pulls and it helps open the lungs as the baby takes their first breath. But when we get that negative pressure at delivery from the chest recoil, sometimes it's too rapid, and that can cause those fragile lungs to tear. So a pneumothorax can happen during delivery. It can also happen spontaneously after delivery because the lung tissue is just so fragile. Overventilation is one potential cause. They have too much pressure. What does it look like? The baby is maybe apneic or maybe tachypneic. They're trying to get a lot of air in and it's not working. They may have a sudden desaturation. Their oxygen level drops suddenly. They have oxygen desaturation, and we try to do something and it doesn't get better. Their oxygen's decreased, or they're put on CPAP or whatever, and it doesn't get better. They may have grunting, nasal flaring, retractions, all that's trying to get more air in. If you listen to that baby's lungs, you may actually hear that there are less or no breath sounds on the affected side. If you look at their chest, it may not be expanding equally on each side. And the change in location of those lungs may actually change where you can best hear the heart. We may also see bradycardia, the heart rate drops, and cyanosis. This is an emergency. They don't tolerate this for very long. They may be treated with needle aspiration. The provider may actually use a needle to aspirate the air, or place a chest tube to try to keep the lung inflated for a little bit longer. Sometimes they may do a nitrogen washout, short-term, 100% oxygen to accelerate the absorption of free air. Okay, in the next section, we're going to talk about a GI complication.